Hey everyone, today we are going to discuss a very important topic, that is acute graft rejection. What is acute graft rejection? Acute graft rejection is a very common type of transplant rejection, almost accounting for more than 50% of graft rejection. And here, by the definition, remember by the definition, it should occur within days to weeks and it should be less than 6 months. If it is beyond 6 months, then you will call it as chronic rejection. So, important timeline: hyperacute less than 48 hours, acute between 48 hours and 6 months, and chronic is more than 6 months. These you have to remember objectively. And there is a division: there is a T cell mediated and humoral rejection. Both are involved in case of acute rejection. Both the mechanisms are involved. And what are the causes? So causes could be inadequate immunosuppression. The immunosuppressive therapy is inadequately given or patient is not adhering to that. HLA mismatch is also occurring. That is also one of the cause. And here, cellular rejection. Here, what will happen? The CD4 helper cells react with the MSC2 of the dendritic cells of the donor cells. And here, there is a activation to Th1 helper cells, and they causes macrophage activation by IFN gamma secretion, and macrophages causes damage to the graft vasculature. Also, there is a parenchymal damage. That is very important feature of cellular rejection. So parenchymal rejection, suppose for example, if it is kidney, the parenchymal damage will be seen over the tubules. The tubulitis will occur. That is an important feature. And also there will be endothelial damage also will be seen. And apart from that, CD8 T cells will also get activated on exposure to MSC1 molecule of the dendritic cells of the donors. So here there will be cytotoxicity. CD8 T cell will also cause cytotoxic parenchymal damage. And important thing, here you can see the image where you can see that there is a kidney that has been mottled. The graft mottling has occurred, and there is a severe edema and inflammation, and there are some hemorrhages over there. Blackish areas are over there over the surface. So these are important features. And here in the image, microscopic image, you can see the blood vessels being infiltrated by lymphocytes and the renal tubules. So you can see in the upper portion, there are tubules which are infiltrated by lymphocytes. So tubular damage, blood vessel damage, both are occurring over here. And here you see that there is a blood vessel that has been damaged over here, and there are tubulitis that is being seen. So both are being damaged over here. This is the higher magnification, much better view. And now coming to the other mode of rejection, that is humoral rejection. So both cellular and humoral rejections occur in acute type of rejection. It is due to HLA antibodies, and the antibodies are HLA antibodies. It may be preformed antibodies or it may be formed after transplantation. So here what happens? There is antibodies which activate the complement system, and that causes the neutrophil to cause vascular damage. So complements act as a chemoattractant for the neutrophils and causes damage. So antibody mediated damage. So important which type of reaction it is, you will call it as type 2 hypersensitivity reaction. And presence of complement activation is signified by C4D in the inflammatory tissue. So C4D, if we use monoclonal antibody against C4D, that will be highlighted. That is positive over here. So that is very important thing in acute humoral rejection. So C4D, if it is positive in the inflammatory infiltrate, you will call it as humoral rejection. If C4D is negative, then this acute rejection is probably the cellular one. And here you can see in the image, the blood vessels are being targeted. So important thing is that these humoral rejection, here the most important target is endothelium, endothelium of the capillaries or blood vessels, that is being seen over here. And here you can see that C4D staining is being positive over the peritubular capillaries. Parenchymal damage is less common in case of antibody mediated damage or humoral rejections, whereas parenchymal damage is more seen in cellular rejections. Treatment. Now, how do you treat the patient? So the treatment has to be done by doing immunosuppression, adequate immunosuppression. That is the first mode that can prevent these kind of acute rejections. High dose steroid is highly recommended as the first line of therapy in acute cellular rejection, and some lymphocyte depleting antibodies may also be used in acute cellular rejection. Now, how to treat acute humoral rejection? You will do plasmapheresis, that is plasma exchange. You can give intravenous immunoglobulin, and corticosteroid can also be used as an adjunct. So have a quick recap of the findings what we discussed. So acute humoral rejection, acute cellular rejection, by definition, it should be less than 6 months. And here the important causes are HLA mismatch, or there is a basically inadequate immunosuppression, that are the important causes. Cellular rejection could be both CD4 and CD8, and here there is a damage to both parenchyma and endothelium is implicated, whereas in humoral rejection, there is a preformed or there is an formation of antibodies after the transplantation. There is an anti-HLA antibody that is being formed, and it is more common. It may be more common in sensitized in individuals who are having prior blood transfusion and all. And this acute humoral rejection is signified by complement activation. So here you will see the C4D immunostaining. And the treatment we discussed: acute cellular rejection with steroid primarily you have to treat, and acute humoral rejection you can treat it by plasma exchange and intravenous immunoglobulin. Now, thank you for your patient hearing. Please like, share, and subscribe, and also let us know what kind of videos do you would like to see in my channel. Thank you. And we are also offering right now the 10 days crash courses. So you, for any kind of exam preparation, whether you are doing MBBS or you are doing preparing for USMLE, NEET PG, so in 10 days, I will make you tuned for that kind of examination by personalized one-on-one sessions and some study material, focused intensive training for 10 days. So don't miss out and contact me right now. Thank you.